طيب السلام عليكم ورحمة الله. حياكم الله جميعا in this session of the SARO round or SARO series. As you know, it's a series of lectures that we always present monthly, supervised and arranged by Saudi Association of Radiation Oncologists. So it's my honor and pleasure to introduce my dear friend, Dr. Ibrahim Alomary, who's going to be moderating this session. Dr. Ibrahim, and all of you know him, he has extensive experience in lymphoma along with other tumor sites. So that's why he's moderating this session. So without further ado, I would like to welcome Dr. Ibrahim, and now you can start moderating and take us through the discussion, inshallah, after you present the speaker of today, Dr. Ibrahim.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Dr. Majid, for the introduction, and thank you for the SARO Scientific Committee to host this series, and hopefully it will continue, as long as we have good audience and great presentation and presenters like Dr. Huda. So Dr. Huda Altoukhi is a radiation oncologist who graduated from King Abdulaziz University Hospital, and then she pursued her training in McGill. Then after she finished her residency, she did 1 year of CNS, if I'm not mistaken, and lymphoma. And today she will be talking about contemporary radiation techniques for lymphoma. Dr. Huda, welcome, and the platform is yours.
Thank you, Doctor. Assalamu alaikum wa rahmatullah wa barakatuh. Thank you for having me. I'm very happy to be presenting to everyone today. So my topic today is about contemporary RT techniques for lymphoma. I will be discussing 2 articles today. Both articles were published last year, sorry, by the ILROG, the International Lymphoma Radiation Oncology Group. The first article is about involved site radiation therapy, and it was published March 2020. And as we all know, lymphoma is a very extensive disease. It has very, very different sites, very different subtypes, whether it's nodal or extranodal disease, depending on the stage, depending on the response to chemotherapy, Hodgkin, non-Hodgkin, depending on how many cycles of chemotherapy the patients got, and the disease response and the PET DeVille stage. All of this affects our volumes and affects our doses. So what they did in the ILROG group is try to give us some guidelines to help us with the doses and the volumes. And this is, they're not their first guidelines. They published a few years ago the same thing. And I think it's a very useful reference for us to use to go back to, because you can never be sure with lymphoma. It's always changing, and it's always very, very confusing. So before we go through involved site radiation therapy, let's go back to involved field radiation therapy, which was the standard of care many, many years ago for a very long time. So involved field radiation therapy, as you can see here from the image, is treatment based on the entire nodal region, based on the RAI classification, regardless of the nodal group that's involved. So even if we have only one nodal area that's involved, we're going to treat the entire nodal area. And that provided very excellent local control, but at the expense of toxicity for the patient. And then we have involved nodal radiation therapy, which is kind of the opposite of involved field, which is a concept that came up by the EORTC for Hodgkin lymphoma, for early stage Hodgkin lymphoma. They came up with that in 2006. And as you can see from the images here, and this is the initial pre-chemo PET, and this is the nodal group that is involved, and this is the GTV post-chemo, and this is our CTV. So as you can see, it is a very conformal type of radiation therapy, and we can treat that provided that we have optimal imaging, and that is not always provided. So INRT uses the smallest effective treatment volume individualized to the patient's disease distribution, avoiding the potentially unnecessary normal tissue exposure and toxicity risks associated with involved field radiation therapy. It is used with early stage Hodgkin lymphoma, assuming the ability of chemotherapy to control adjacent potential microscopic disease. And this was proved to be effective in a prospective randomized trial. And maybe we can discuss this later on in the discussion of any of the colleagues have done this in their practice. I believe it's very famous in Europe, or maybe the colleagues who did their practice in France, but I don't think it's very popular in North America. So why INRT is not always feasible or not very practical? Because two key considerations need to be addressed. First of all, we need to require optimal imaging for accurate disease localization. So we need to make sure that the patient is scanned in a certain way throughout their disease process. So us as radiation oncologists, we always see the patients at the end of their disease process. So we either have to see their patients in a multidisciplinary clinic, which is not always done, or we have to see them from the beginning and make sure their diagnostic images are done in a certain way. The second key consideration is we need precise co-registration of baseline imaging information with the RT planning CT. So as you can see here, a slight change in the patient's neck position changes everything for us in terms of our volume. The same thing here, free breathing or breath hold changes everything, as you very well know. And of course, the arm position changes everything. So moving on to involved site radiation therapy. In 2014, the International Lymphoma Radiation Oncology Group introduced involved site radiation therapy, which is a slightly larger volume intended to allow for these commonly encountered uncertainties. ISRT is internationally recognized as the standard of care for malignant lymphoma when optimal imaging is not available. I will go through a few examples of what they recommend as ISRT. There is increasing evidence that RT doses used in the past are higher than necessary for disease control in this era of combined modality therapy. The goal of modern smaller field radiation therapy is to reduce both treatment volume and treatment dose while maintaining efficacy and minimizing acute and late sequelae. So this is an example of indolent lymphoma. So it's very easy because we don't have the confusion of the pre-chemo PET and post-chemo PET and the changing in volume. So it's very simple. This is our GTV. And as you can see, the CTV is a very small expansion of what we think might be the microscopic disease. There is no need to expand to other lymph node area or other regions, and a slight expansion is sufficient. A dose of 24 gray to 30 gray is enough. That's it. This is what they recommend. Moving on to advanced Hodgkin lymphoma, doses of 24 gray for initial small volume sites with metabolic complete response, after 6 cycles of ABVD, the minimum ISRT volumes should include residual PET positive lesions and residual PET negative masses. The CTV should be enlarged to include slowly responding sites, meaning positive interim PET without exceeding the dose constraints. This is an example of a diffuse large B-cell lymphoma in the head and neck area. As you can see, the initial PET was positive for an upper and middle neck nodes. And here, the CTV included that. It did not go to the lower neck area because this was never involved. So the CTV includes initially involved nodes, including sites that have normalized after systemic therapy. And this, I wouldn't say a mistake, but something that we usually see, that patients tend to be, people and doctors tend to be generous in head and neck area, maybe because they like to treat it like a head and neck tumors, or just because they like to include a level above or a level below, but the authors here do not recommend it. This is more than sufficient. So if there is metabolic complete response after chemotherapy, the CTV would be contiguous nodes that were enlarged, diagnosed with low FDG avidity should be included in the CTV when necrosis is suspected. Contiguous initially equivocal nodes should be included in the CTV. CTV should not be enlarged to include initially normal nodes. An example of primary mediastinal B-cell lymphoma. This is, the authors are giving an example of a disease that was initially bulky, and they were giving an example of how to pick and choose on what to treat. So this is a disease that had pericardial nodes and upper mediastinal nodes, and they chose to only treat the mediastinal nodes and not the pericardial nodes because of the risk of cardiac toxicity. And this is when to pick and choose the benefits over the risks of radiation. This is another example of mediastinal lymphoma with discrete pericardial nodules. And this is where you also have to refrain from treating because the risk of cardiac toxicity is much higher than the benefit from radiation therapy, and you would have to depend on the systemic treatment alone. Even if we know that the risk of relapse is higher, there's not much that we can offer. Going on to relapse or refractory aggressive lymphoma, and whether the relapse is limited or widespread. So if the relapse is of limited extent, it might be sometimes encompassed within a tolerable treatment volume. In such cases, the CTV may include all relapse sites, including sites in complete response after systemic therapy. Equivocal nodes adjacent to definite relapse sites should generally be included in the CTV. If relapse sites are close to sites at initial diagnosis, consideration may be given to include the original disease extent in the CTV. So this is an example of a stage 2 Hodgkin lymphoma with relapse after 6 cycles of ABVD. So this is the initial disease at diagnosis, and this is the relapse. And this is their volume. So they treated the relapse site, they gave it 30 grays, and they treated everything else with 20 gray because of myocardial toxicity, but they still included the initial disease as well. But of course, if it's widespread relapse, it is usually not feasible to encompass widespread disease sites in a tolerable ISRT volume. It may be possible to identify sites at elevated risk of relapse after systemic therapy. Sites of residual PET positive disease after systemic therapy constitute the GTV. Clinically critical sites, example, risk of spinal cord compression or proximal airway compression may be considered for inclusion in a CTV. So For conclusion, the application of ISRT varies according to the lymphoma clinic spectrum and according to the quality and applicability of available imaging. Emerging data on patterns of failure after the standard treatment will likely influence the application of ISRT in the future. The efficacy of immunotherapy or immunochemotherapy for control of systemic disease may provide increasing confidence in the use of smaller CTV margins in the future. But for now, I think ISRT is the standard care until we're more confident with our images and with our volumes. Before we move on to the questions and discussion, I would like to go through the second article briefly because it's much more brief. So this is also an article that was published the LDROG group as well. It was published May 2020 as well. And these were their emergency guidelines for radiation therapy of hematological malignancies. And I think it's also very useful as a reference to use during the COVID-19 pandemic. Hopefully we don't need them that long, but during the situation that we're in, I think it's still valid for us to use them as long as the situation is unstable. So basically, they give us 3 options for patients with hematological malignancies in terms of radiation therapy. And keeping in mind, this was published last year during the peak of pandemic and situation was chaotic, but it still applies to everything going on this year. So their first solution is omitting radiation therapy. When the risk of severe outcomes from COVID-19 outweighs the benefit. So this still might apply to some centers or some hospital. Each center and each city is different. So if you think that your center is still, the risk of COVID-19 is still very high, these are the patients that you can cancel their treatment or you can refuse to treat them at the moment. So patients who are palliative, where alternative settings can be offered, like pain control, patients with localized low-grade lymphomas, if it's completely excised, like follicular lymphoma or marginal zone lymphoma, or if it's consolidation RT for diffuse large B-cell lymphoma or aggressive non-Hodgkin lymphoma in patients who have completed a full chemotherapy course and achieved a complete response. The second option is to delay radiation therapy when there is a little expected adverse effect on the outcome. So for example, who are the patients that we can delay the treatment for? So patients who have asymptomatic localized low-grade lymphomas, localized nodular lymphocyte predominant Hodgkin lymphoma, palliative setting for patients who are stable, or patients who develop COVID-19 infection and their malignancy is not progressing. The third option, which is the most useful and the most helpful, is shortening the RT course. So they provide us with an alternative hypofractionation regimen with the aim of maintaining a high cure or palliation without undue toxicity. Hypofractionation will always influence the effective dose for the effects. Risks need to be carefully weighed. Radiobiological considerations and clinical experiences were used by the LROC task force to generate the suggested altered fractionation schedules. And in the article, they list all types of lymphomas, whether it's curative or palliative, and list all the dose and fractionation that you might use in the normal fractionation and give you the option of hypofractionation and B calculation. So you don't have to, again, you don't have to worry. And whether it's curative, it's palliative, they have all the options and they have everything listed, and whether you're worried about cord compression or no cord compression and so on and so forth. I think it's very useful and I think this is the time to use it. So just like with the breast fast forward trial, how it was life-saving in these times, I think this is the time to use this. And I hope it can be of use to everyone. So that's it. Thank you very much.
Thank you so much, Dr. Huda, for this brief and elegantly done presentation. We all know that, since the HD10 medical oncologists are trying to get us away from treating Hodgkin lymphoma by reducing the dose and then increasing the chemotherapy cycle and using, escalated BIACOP chemotherapy and in early and advanced or unfavorable. The HD6 really didn't do us any good, although study, but they're still, citing that study, even though they know that we don't use the techniques that used in that trial. So hopefully we will, enlighten them that radiation is still, an integral part of treating Hodgkin lymphoma and lymphoma in general in all sites. With this, I will open the door for questions. So please. Any questions to Dr. Huda?
Assalamu alaikum.
Assalamu rahmatullah. Ahla wa sahla.
Excellent, Dr. Huda. Thank you so much. This is a great summary. This is just an interesting point. I would like to see what you think is that the involved site has become the standard of care. Yet all the randomized trials in Hodgkin and non-Hodgkin lymphoma use either involved nodal or involved field. So we don't have level 1 or phase 3 randomized trials that have used the involved site radiotherapy, which is very unusual for things that become standard of care. It is based on retrospective and dosimetric studies that end up leading to a consensus by the LROD. So what's your take on this? This is not something that we are used to in other sites.
I just wanted to ask you, do you still use involved field radiation in your practice?
No, I'm saying that everybody now is using involved site, but we are used to things to become the standard of care when they are backed up by level 1 phase 3 trials. Yet all the phase 3 trials that have been published so far and reported are involved field or involved nodal. So this is kind of anomaly in terms of looking at the literature and other sites. That's the point that I'm trying to make.
True. But the articles that use involved node are mostly coming from Europe, but this is why we don't follow them. And the ones that use involved field, to be honest, I don't have an explanation to why they're still using involved field, to be quite honest. It's not something that should be used in this era. And
what do you think of Mut'ab?
I don't.
Okay. طبعا the involved site is more practical, although, as you said, it's not been looked at in details. It's easier. It accounts for the the positioning, the movement, and everything. And I think in where we came from Canada, basically, the techniques were not that great up until recently, where you had more ability to localize your disease, whether using the breath holding techniques or other techniques that is available. So maybe that is the reason that it's not as much being studied as an involved site or involved field. I know that, yes, as Dr. Altoukhi said, in Europe, it's an involved nodal right away. They don't even consider sites anymore. I think in North America, we're still more hesitant because of the technical and logistic part of it. What do you think, Majid? ما شاء الله عليك, you are well informed. So what is your take on this?
Talking to me?
Yes, Abu Sarah.
Yes. Yeah. No, I think it is not. I'm just saying that this is very unusual. That the standard of care is based on, let's say, consensus rather than level 1 evidence. And I think this is unique for lymphoma. You don't see it in other sites. Why? I have no idea, but I think that everybody now, including the guidelines, say involved sites radiotherapy. I was just trying to make the point that it is consensus-based and not evidence-based in terms of level 1.
Yes.
But, of course, it's backed up by retrospective and dosimetric studies showing the advantage. And of course, the eliminating the involved nodal, because this is kind of a very special situation. And even for the Europeans, they use it in early Hodgkin site. Looking at the bulk of the trials that we're actually following and using and quoting, they are involved field, the majority. Another point I would like to make is when we discuss with our colleagues in medical oncology or hematology, is that to them, they seem to oversee the fact that while, let's say, ABVD of today is the same as ABVD 20 years ago, R-CHOP of today is the same as R-CHOP of, let's say, I don't know, 20 years ago, but radiation therapy of today is not like the 20 years ago. They seem to see it, all the same, while we know it's quite different. It's like telling someone that iPhone 1 is like iPhone 11. So it is very important to explain to them that things have changed while they stayed the same with them, and that they should not, judge radiotherapy by old data, especially when you look at data that was published based on information like 20 years ago. So I just want to make sure that, we always make that clear to our colleagues, because they use the blanket of radiotherapy as if it is the same across the decades. Thank you. That's for me.
Thank you so much, Dr. Uthman. I totally agree with you. I think it's our short, coming that we don't show them exactly what is the difference between 20 years ago and now, as much as they need to see it. Yes, we talk about it. We show them the difference between involved subtotal, total, subtotal, involved field, but they are not involved with us in seeing exactly how we are doing it. So I think we need to teach them more, and we need to be involved more in their rounds and difference. So any further questions?
Assalamu alaikum. I can further just elaborate on what Dr. Majid was saying. is that I think, Dr. Majid, your statement about using ISRT and that it's based on consensus, I think it's partially true. First, we need to differentiate between the use when we're saying now ISRT in general, because it's just combining a common ground between IFRT and INRT. So, but we as oncologists, we know that usually ISRT, we're using it in terms of combined modality therapy, meaning we're just treating the initial sites of involvement. And IFRT, I would keep it for patients who are treated with definitive radiation because by default, we are treating just a larger area. And we're just, you know, we're treating the entire involved field. Like, for example, in low-grade lymphomas, you're using an IFRT because you have to treat all of the subclinical and the obvious disease. For INRT, we practically don't do that. The main reason is that the patients are not, they're not positioned in the same, their diagnostic PET scan or diagnostic CT scan is not in the same position as their CT SIM. So we can't actually fuse both CT scans, and there's going to be a problem in fusion and then knowing exactly which node or which area that needs to be treated. So I think guidelines is probably appropriate, just calling ISRT in general for all of the areas. But I mean, I understand what you're trying to say is that it's based on consensus and not on level 1 evidence.
Thank you, Dr. Tagreed. Who has PET CT SIM in the center and using it for treating lymphomas? Anyone?
No.
Yeah. Although we do have a CT, you know, PET CT SIM, but we never used it for, I never used it for lymphoma. Part of it is because of the, you know, the need for using, you know, the PET scan for all sites, as well as the logistic of having the FDG. So I think if we use, you know, PET CT more, that will be, you know, a step forward towards using the involved nodal radiation more. So great, you know, interaction. Any further question, please?
If you allow me, Dr. Yasser Bahadur, he was raising his hand.
Oh, I don't see that, sorry, in my screen. Please, Yasser, for sure.
Yes, thank you. I would like to thank all of you. It's a great discussion. Actually, I raised my hand and then I put it down again because what I was going to say, mashallah, Tagreed sabaqatni fi. But I just want to confirm that it's phases. Yani something. Yani just going back to what Dr. Majid was saying. Yani we did not need a randomized trial when we moved from cobalt to linear accelerators, and we did not need randomized trial to go to 3D and then to IMRT. It looks like it's yani goes by common sense if we can start with this introduction. Now coming back to the lymphoma, as we know, lymphoma is a highly curable disease, and the aim in the last few years mainly to reduce the late toxicity rather than to improve on the control, or because we reach kind of a plateau. So it makes sense in reducing volume, less chemotherapy, de-escalating the dose. It's just a point that I wanted to make in regard to, in addition to what all the colleagues said, of course.
Thank you so much, Dr. Bahadur. Dr. Altoukhi, in your second presentation, the use of radiation in lymphoma during COVID, you know, one of the things that we were taught that hypofractionation is, you know, not favorable when you're treating lymphoma. Have you used the hypofractionation techniques in treating your patients, and how did that go? Because I remember I treated one patient when I came back with 30 10 fraction and of the neck, and it was really tough.
Yes, yes. This is what we learned We don't usually hypofractionate, and this is why they emphasize in the article that radiobiological consideration has been taken care of. And if you look into the schedule, they don't hypofractionate as much. And yes, I have been doing it. I did it when, as I said, in the months when the pandemic was at its peak, when it was necessary. And to say the truth, we didn't find that the results were bad. The patients were tolerating it really well, to be quite honest.
Okay, great.
So
Thank
instead
you.
of giving, for example, 30 and 15, we were giving like 25 and 5. And the patients were, of course, depending on the site, but the patients were tolerating it really well. And of course, we were going by the guidelines, whatever they were suggesting.
Great. Thank you. Thank you so much.
Yes. I agree as well with Dr. Huda. Even at our center, myself and Dr. Fahad Ruwais, we've been implementing hypofractionation. At least we've treated probably 10 patients in total with hypofractionation. And we're actually, I mean, I also think about the patients who are coming from remote areas. It's a lot easier to give them hypofractionated, especially if it's not a mediastinal lymphoma. Like areas where the toxicity is low, it's much easier to give them 25 and 5 rather than bring them for 3 weeks. So in general, of course, short term, we haven't noticed any acute toxicity, but I'm also collecting their data to keep a track.
Great. Thank you so much, Dr. Altoukhi. Any more questions or comments for the audience? Anyone? Okay. I think with this, Dr. Ibrahim Al-Atain, to everyone. Which patient would you omit radiotherapy? And I think he's basically talking about Hodgkin lymphomas. So, Dr. Altoukhi.
Which patients I would omit radiation therapy? So
yes.
Because of the COVID-19, you mean?
I think in general.
Yes.
Oh, and COVID.
Yeah, with the guidelines.
Yeah.
So they specify, so patients who are palliative, if other options are present, for example, pain control. Patients who I think they say if they have a localized disease that are asymptomatic. And the third options, for example, if patients who have a complete response, a diffuse large B-cell lymphoma, who have finished their chemotherapy and have a complete response. So they have those three options only. So they specify who, like exactly which patients to omit radiation therapy. It's not like, luckily it's not us to decide. It's not up to us to decide which patients to omit radiation therapy to.
Thank you. Does anybody still use 30 and 15 for early stage Hodgkin lymphomas? I know we have an evidence, we have the HD10 that shows us that 20 is equal to 30, but I know that some people are still skeptical about, going down, and some people are still. So, anyone?
If it meets the criteria for German Hodgkin 10, then it's 20 gray. If not and unfavorable, then it's 30. But we've used 20.
I would still use 30 if it's unfavorable.
Totally.
Yes.
I only use 20 if the patient has a very favorable disease.
Good.
Yes.
Yes.
I have another point to discuss. I don't know what's the differences in, generally in the centers here in KSA with regards to the patient's immobilization for mediastinal lymphoma. If you look at the different guidelines, for example, especially for females, with the aim of avoiding more of breast tissue, they prefer an inclined position of 10 to 15 degrees. And then if you need to put an S frame or a U frame for immobilization of the head and neck area, we at our center, we do not have the proper immobilization devices for this. So, for example, we have either the T-board where the patient cannot incline, or we have the breastboard where the patient can incline, but the arms are going to be up, and putting the arms up actually is not a good idea for avoiding the breast, because the breasts will go higher, so it comes more in the field. Just a thought of asking what other centers do, or if you guys are using a vac lock or a wedge or some sort of different technique.
I'll tell you what we use. We use 5-point shell and arms down, and then we use avoiding sectors.
So with VMAT, you mean, and avoiding sectors, but you do a little bit of inclination.
Well, that's the problem. Yes, you have to, because this is the best you can get. So you have to keep that in mind. It's not optimum, but it's
yes.
Whatever is available at your center, and you have to keep that in mind when you use your volumes.
All right, but you said it's only 5 degrees.
It's flat.
That's not a lot. Flat, okay, yeah, that's not.
Yeah.
I don't think that helps.
Yeah, because with inclination, okay, you can't use the shell.
The shell, exactly.
Yeah. Anyone else?
We do just like you, Rometra, just like you.
Okay, Dr. Altoukhi, any special technique you use when you treat mediastinal lymphomas?
No, nothing special. No.
Yeah, so pretty much I think we are all in the same boat. We just use whatever we have, and then we build on it.
Of course, VMAT, that's what we're talking about.
Yeah. Oh yeah. I don't think anyone still uses 3D conformal for mediastinal lymphomas, because that will be a nightmare nowadays.
Not 3D conformal, but occasionally IMRT, just because sometimes it has better coverage with with areas that overlap with the lung. We've noticed that we compared the VMAT with the IMRT, and IMRT ends up being better in terms of coverage.
Yeah. What is your dose limits though for the lung and the heart? What is your V5, V20 that you accept?
So there is a criteria from MD Anderson for the lung and the heart. The lung we go, so the lower doses, I think the V25 less than, or V5 less than 55 to 60, and then the V10 less than 40, V20 less than 35, V25 less than 30 something. And we look at the mean lung dose. But now I think there is a newer guideline in the same paper that Dr. Huda presented.
Yes.
They've divided different dose constraints for the heart, depending whether the tumor was bulky or non-bulky and what should be optimal. So they're even minimizing it further. I mean, not the way, for example, when we learned a long time ago that the mean heart dose should be less than 26, that's way old now. And then we learned it should be less than, let's say, 10 to 15. Now, even the optimal should be less than 5. So depending on the tumor bulk and I think the aggressiveness of the disease, I think they have now a newer guideline for the lung and the heart.
Yes, they give you the optimum, dose constraint, and then they give you a range, because it's really difficult. I mean, I've tried to go below 50 for the V5. I managed to get a couple of patients, but it's really difficult. It's not easy when you use VMAT.
Exactly, with the VMAT especially, yes.
Yeah.
Agree.
Okay, So any further questions or comments from the audience? You know, the good thing, the great thing about lymphoma, it's a disease of all sides, you know, regardless of the, you know, what you preference in sites. When you treat lymphoma, you end up treating all sites. And, you know, the beauty is you have to, you know, keep, you know, knowledge of all the sites and all the constraints. And, you know, although the doses are low, but still it is challenging in some sites.
I agree, yes.
That is the beauty of lymphoma.
Yes. Right. Okay. If there are no more questions or comments, I will give the platform to Dr. Majid Al-Ghamdi. Thank you so much, Dr. Altoukhi, for this elegant presentation. Thank you all for your comment and your discussion. And thank you, Dr. Al-Ghamdi, for giving us the chance to moderate and present.
Thank you so much. Thank you. My pleasure.
Thank you, Dr. Ibrahim, for